This deposit is located in the subepithelial region, so they are classically the subepithelial deposits. Okay, number two, they are also, sometimes they say they are in the subepithelial region, but classically they are in between the epithelial cells. So that is why these deposits are also called as membranous in nature. Sometimes membranous and subepithelial deposits are also used interchangeably. The third type of location, now if you see, this is the glomerular basement membrane and this is the endothelium. Now just beneath the endothelium you can see these black deposits. So this is the classical subendothelial deposits. These are the subendothelial deposits. And what are these deposits? Yes, please tell me, what are these deposits? Can anyone tell me what deposits are these which are present? Very good. So these are your mesangial deposits. These are your mesangial deposits. Okay, so this is the two pattern. So as I've already told you, in most of the immune complex mechanism you will see this characteristic granular pattern. So you can see they are in the form of granules. They are not very linear. Granules mean somewhat like this. Linear means completely ribbon like straight. So the only pattern which is having the linear variety is the anti-glomerular basement membrane disease. Rest all the patterns will contain the granular pattern of deposition. Now what we are going to do, we are now going to start the pathological response to glomerular injury. Now this part of this lecture, that is the pathological response to glomerular injury, is a very important part to understand. A lot of questions are coming from this part, especially the question is this. Okay, the question is this, the mechanism. The very important question is, what is the mechanism of glomerular injury? So discuss the mechanisms of glomerular injury. Okay, this is a very important exam question, especially in post graduation it is coming for 10 marks, and in undergraduation also this year itself it has come. I have shared one paper, it can come anywhere between 5 to 10 marks. This question is asked. One question paper I have already shared in the group which is having one question to this particular answer. So before we directly go into the mechanism of glomerular injury, we first should understand, or we first should make an effort to understand that what is the pathological response to glomerular injury. That means how our kidney, or how the different parts of our kidney, they are responding to different kinds of a stimulus. So let us try and understand these basics first. The first kind of response that the kidney can show is called as hypercellularity. Now in which kind of kidney disease you will see hypercellularity? For example, in inflammatory disease of the glomerulus. So any condition where there is an inflammation of the glomerulus, what is it called as? For example, in nephritic syndrome that we had seen. So in any inflammatory disease of the glomerulus, you will see that there is an increase in the number of cells. So which cells will increase? There will be an increase in proliferation of the mesangial cells, increase in proliferation of the endothelial cells. That is also accompanied by infiltration of the leukocytes, might be mononuclear cells, might be neutrophils also. And in extreme conditions or in worse conditions or worse situations, you can also have the crescent formation, which is characterized by epithelial cell proliferation plus fibrin deposition. More will be discussed about the crescent formation when I will teach you about the pathogenesis of RPGN, that is the rapidly progressive glomerulonephritis. Remember, this is not any kind of disease. RPGN can occur in any kind of nephritic or nephrotic syndrome. It is just denoting a severe form of nephritic or kidney injury. Okay, so the number one thing is, whenever there is any kind of inflammation, they will be characterized by hypercellularity, and I have discussed the points also regarding that. The second kind of response is the basement membrane thickening. Okay, so the second kind of response is the basement membrane thickening. So that is appreciated if you see under the microscope, under the low power or light microscopy, you will see that there is a thickening of the capillary walls. Okay, so for example, if this is the glomerulus normally, and you will have multiple, capillaries over here. So whatever capillaries you see, okay, normally they are like this, they will become, they will become more visible. They will be thickened like this. Okay. This is the normal, this is the abnormal thickening of the glomerular capillaries, which is best seen with PAS stain. Okay, PAS stain. Now, if you do the electron microscopic study, if you do the EM study, so electron microscopy is characterized by three important things. Means if you see this basement membrane thickening, okay, if you see in the electron microscopy, it will reveal three important things. So there are three ways in which the deposition can occur. Either there can be an immune complex deposition, which might either deposit in the subendothelial space, or they might deposit in the subepithelial cells. So immune complex deposition means that antigen antibody complex was formed, which activated the complement system. Along with that, there was a complex formation which can either deposit in the subendothelial space or in the subepithelial space. Or in the second scenario, there can be increased synthesis of the protein components of the basement membrane. So for example, in case of diabetic glomerulosclerosis, so what is the characteristic lesion of diabetic glomerulosclerosis? Yes, what do we see? Do you remember the KW lesions, the Kimmelston-Wilson lesion? That is a characteristic lesions that we see in diabetic nephropathy. Okay. Now, or in the third important way, you can see formation of additional layers of the glomerular basement membrane. This is also called as a splitting of the glomerular basement membrane. So instead of a single glomerular basement membrane, you might see two types of or two additional layer. Actually, it is caused by deposition of some material in between, and they cause the splitting of the glomerular basement membrane. So it seems like that an extra layer of glomerular basement membrane is attached. So these are the patterns that we can see of basement membrane thickening or deposition. Okay, so light microscopy we saw how the deposition and the thickness was, and in the electron microscopy we have also discussed the immune complex deposition in subendothelial subepithelial manner, or increased synthesis of protein components of the basement membrane, that is diabetic glomerulosclerosis, and also we have seen the formation of additional layers of the basement membrane, that is in and the example for this condition where you can see the duplication or splitting of the membrane is membranoproliferative glomerulonephritis. So there are two types actually, type 1 and type 2, and this splitting you will see in both the kinds. Okay. The third kind of pathological response of a glomerulus that we will see, it is called as hyalinosis and sclerosis. Now there is a difference. Now you know hyalinosis. We have already read about intracellular accumulations, wherein one of the changes was hyaline change, if you will remember. That is characterized by accumulation of amorphous material that is homogeneous and eosinophilic by light microscopy. Okay, so this amorphous material, that is this is nothing but this is representing hyaline change, and hyaline change is what? Nothing but the deposition of proteins. In this case, these are actually the plasma proteins which has transferred from the circulation into the glomerulus. Is this point very clear to everyone? So what is hyalinosis? So when the hyalinosis is extensive, it is going to obliterate the capillary lumen altogether. So if this is the normal capillary, then there will be so much of deposit that the lumen might become completely obliterated. Now, what are the stimulus for this kind of hyalinosis injury? Due to the endothelial or capillary wall injury. So this was the number one, that was hyalinosis. The number two, we have the sclerosis. Now sclerosis is characterized by extracellular deposition of collagenous matrix. Okay, so over here there is a deposition of collagen. It is not the deposition of plasma protein component. So deposition of plasma protein component or any protein component that will give the amorphous eosinophilic appearance, we call it as hyalinosis. Okay, so over here sclerosis is there is a deposition of collagenous matrix. Now this sclerosis might obliterate the capillary lumen. Okay, and very important, sclerosis usually involves the mesenterium, as in case of glomerulosclerosis, or it might involve the capillary loops as well. Okay. Now, before we go into the details of how the response is there, we want to understand about the basic histological nomenclature of kidney injury. So whenever we use the term diffuse in histological terms, okay, we are saying that it involves all the glomerulus in a kidney. So for example, this is the entire kidney. This is one glomerulus, second, third, fourth. So over here, all the glomerulus are involved. That is a diffuse change. Okay. Now, what is the meaning of global? Global means involving or portion of a single glomerulus. So this is one kidney. It has many. So it is involving just one portion of a single glomerulus, that is called as a global, involving all portion, means the entire glomerulus is involved. It is talking about a single glomerulus. So the term global means single glomerulus, whereas the term focal means involving fraction of the glomerulus of the kidney. So one kidney is having 1, 2, 3, 4 glomerulus. So for example, 1 and 2, this 2 is involved, this 2 is not involved. So we will say that in comparison to the first, okay, where there was a diffuse involvement, over here there's a partial involvement of the glomerulus, that is the focal process. And segmental is again, it is at the single level, it is at the individual level. So it is affecting a part of each glomerulus. So for example, this is the kidney having different glomerulus. So over here only one part, okay, a small part of each glomerulus is involved, that is called as segmental change, that is affecting part of each glomerulus. Whereas the capillary loop or mesangial, when we use the term, when it is any kind of pathology is involving the capillary or the mesangial regions. So always remember, any kind of acute glomerular response, it results in hypercellularity, whereas any kind of chronic glomerular response leads to basement membrane thickening along with hyalinosis as well as sclerosis, Okay. Is this point very clear to everyone? Okay. Now we are going to go towards the pathogenesis of glomerular injury. So we have to understand that immune mechanisms, they are underlying most forms of primary glomerular disease and many secondary glomerular disease. Primary glomerulopathies are those wherein the kidney is the one which is primarily affected and there is no other systemic disorder. Whereas secondary form of glomerular disorder is one wherein basically in the secondary variety it is occurring secondary to SLE or some other kind of disease. Yes. So focal change, someone has asked about the focal change again. Always remember, focal change means it is involving a fraction of the glomeruli of the kidney. So for example, if there are 4 glomeruli in the kidney, out of the 4 glomeruli, for example, 2 will be involved. That is called as a focal change. Very clear to everyone? Okay. Now let us discuss. So there are many mechanisms of glomerular injury. Okay, and the most important mechanism of glomerular injury, if you see, they are the immune mechanism of glomerular injury. Very, very important. And the immune mechanism, they can be classified into various ways. So there is number 1, antibody mediated injury, cell mediated injury, and thirdly there is an activation of the alternate complement pathway. So these are the 3 very important types, and out of this antibody mediated injury will form the majority of the mechanisms of glomerular injury. So this antibody mediated injury can either be because of in situ immune complex deposition, which is the major cause of antibody mediated injury, or it can be because of circulating immune complex deposition. So first you have to understand what is the meaning and difference between in situ and circulating. See, in situ means that whatever complex formation is there, it is forming at the level of the kidney only. That is the meaning of in situ complex formation. Whereas when we are looking at the circulating immune complex deposition, when the term circulating means that the immune complex was formed in the circulation and from there it has deposited in the kidney. So this is the difference between the in situ and the circulating immune complex deposition. Always remember, the in situ immune complex deposition is a major cause as compared to the circulating immune complex deposition. So over here in the in situ form, the antibodies, they react with the fixed intrinsic glomerular tissues or antigens. So there is some kind of antigen which is altered at the level of the glomerulus or at the level of the kidney. So the antibodies are directly interacting with the fixed intrinsic glomerular or tissue antigen. So what are these antigens against which they are acting? For example, the non-collagenous domain of type 4 collagen antigen. Okay, they are classically the antigen responsible for the complex formation in anti-glomerular basement membrane nephritis. Another type of antigen is the PLA2R antigen. Okay, PLA2R antigen, this is the antigen which is involved in membranous nephropathy. And thirdly, there can be certain mesangial antigen or other antigens. So these are the fixed intrinsic glomerular or tissue antigen in case of in situ complex deposition. Now the antibodies, they can react with certain antigens which by itself was not present in the kidney, but it was believed to be planted in the kidney. So what are the antigens that can plant in the kidney? So there can be certain endogenous antigens like the DNA, nuclear protein or immunoglobulin. These can go and they can get planted inside the kidney and they can itself act as an antigen. Or there can be an exogenous source of this planted antigen. For example, any infectious agents or drugs is there, they can go and get planted. Okay, they can go directly and get planted. Okay, so this is about the in situ immune complex deposition, which is the major cause. Now the other cause is your circulating immune complex deposition, wherein I told you the antigen antibody complex is formed in the circulation and after that they are deposited in the kidney. So again over here it can be endogenous. So endogenous complexes, basically it can form against DNA and tumor antigen, whereas exogenous can form against infectious and drug agents. Okay, so this is the basic classification. Now the first that we are going to understand the diseases. Okay, we are going to understand the diseases which are caused by in situ formation of immune complex. So what are the diseases caused by in situ formation of immune complex? So first of all, this is a local phenomenon characterized by a local formation of immune complex. So the very important example of this that we are reading, that is the disease caused by the in situ formation of immune complex, the very best example is your membranous nephropathy. So very important, there are two things over here. In case of rats, okay, there was one antigen that is called as megalin, which was present in the epithelial cell food process. So the rats, they started to develop antibody against this megalin and they caused a type of glomerular nephritis called as Hayman's model of glomerular nephritis. In case of human beings, okay, there was M-type phospholipase A2 receptor, that is the PLA2R receptor. Now this is the antigen which was responsible for glomerular nephritis in case of membranous nephropathy, and this antigen present in the glomerular epithelial cell membrane, it induced antibody formation and it led to antigen antibody formation in situ, that is at the level of the kidney, leading to what is called as complement activation. Okay, so once this complement activation was there, there was classical in situ immune complex formation. So by electron microscopy, under this form of in situ variety, characteristically you have subepithelial immune complex deposits. Very important, you have subepithelial immune complex deposits. By immunofluorescence, this will show a characteristic granular pattern. This will show a characteristic granular pattern. Now this immune complex, they are going to elicit a host response in the form of thickened glomerular basement membrane appreciated by light microscopy. Hence, this type is also called as membranous variety of glomerulonephritis. So we have just understood about the membranous variety of glomerulonephritis, which is exemplifying the disease caused by in situ formation of immune complexes. I hope this was crystal clear to everyone. Now the second very important, as I told you, the immune complex can have two things. Either some antigen is there which is intrinsically present, for example in the kidney structures. For example, this PLA2 was present in the GBM. Similarly, we can have planted antigens also. So for example, antibodies will form against the planted antigens also in the local immune complex manner. Now these planted antigens, they are not a normal component of the glomerular. So what are these planted antigens? These are nothing but certain cationic molecules, DNA molecules, nucleosomes, nuclear proteins, bacterial products, aggregated large proteins. For example, aggregation of immunoglobulins in the mesengium, immune complexes as well as drugs. So these are the planted antigens which can help in, which can get planted in the kidney and then lead to in situ immune complex formation. Now the second very important mechanism of injury to the glomerulus, okay, is exemplified by the diseases which are caused by antibodies directed against normal components of the glomerular basement membrane. So they are directly, directed against the normal components of the glomerular basement membrane. So over here, the antigen is nothing but the non-collagenous NC1 domain of alpha 3 chain of type 4 collagen in the glomerular basement membrane. So normally this is the normal component of the glomerular basement membrane. Now over here the antibodies are directed against this component, and the disease is called as anti-glomerular basement membrane glomerulonephritis, and over here the antibody is called as anti-glomerular basement membrane antibody. Now once this antibody is formed, it is going to go and cause kidney disease, and in the kidney they will cause a type of glomerulonephritis called as anti-glomerular basement membrane glomerulonephritis, which is a severe necrotizing and crescentic glomerulonephritis, okay, causing RPGN is in around less than 5% of the cases. So this anti-glomerular basement membrane variety of glomerulonephritis is very severe and necrotizing type, and it is basically characterized by crescentic glomerulonephritis, that is the RPGN, in less than 5% of the cases. Whereas these antibodies that is formed against the glomerular basement membrane, they not only attack the kidney but they will also attack the lungs because of the cross reaction against the basement membrane in the lungs, and over here they will cause something called as Goodpasture syndrome. So over here this anti-glomerular basement membrane antibodies is not only causing the kidney disease but they are also causing the lung lesions. Characteristically, if you see in the immunofluorescence, instead of having a granular pattern, they have a characteristic linear diffuse pattern. Now glomerulonephritis, this is the third important variety, the glomerulonephritis, which is resulting from deposition of the circulating immune complex, which is not that much famous now, okay, It is not the major mechanism, okay. So it occurs due to the trapping of circulating antigen antibody complex which has formed within which is depositing inside the glomerulus. Remember, they do not have any specificity for the glomerulus, but why are they localizing in the glomerulus? Solely because of their own physicochemical properties and because of the hemodynamic properties of the glomerulus. So remember, why the circulating antigen antibody complex, they are getting trapped only in the glomerulus. Remember, they do not have any specificity for the glomerulus. It is because of their own physicochemical properties and because of the hemodynamic properties of the glomerulus that they are basically going and depositing in the glomerulus. So what is the source of antigens in case of the circulating immune complex disease? So the antigen in case of endogenous disease, okay, for example, in case of SLE or IgA nephropathy, okay, so in such conditions, antigens can be derived from here and they might lead to circulating immune complex formation. And if you look at exogenous antigens, then infections and tumor antigens, so infections like bacterial infections like streptococcal or hepatitis B or C infection, Treponema pallidum or Plasmodium falciparum, all can trigger the formation of antigens which later on will form circulating immune complex and will go and deposit at the level of the kidney. So just to summarize this pathological mechanism, okay, the immune mechanism in detail. So we are basically we are talking about the immune mechanisms in details over here. So in case of the immune mechanisms, if you see, there are three things, okay. So very importantly over here we saw that there can be a circulating immune complex deposition over here. So you can appreciate over here that over here you can see characteristically there is a deposition of the immune complex over here, okay. We can see the subendothelial deposition over here in this case. Now secondly, in the in situ variety there are two types, okay. One is either the problem is present at the level of the glomerular basement membrane, so you can see over here the endothelium over here and the deposition is along the GBM, so the deposition is at the level of the glomerular basement membrane. Over here in the circulating immune complex that we will see, usually we are looking at the subendothelial deposit. We are looking at the subendothelial deposit in case of the circulating immune complex deposition, and in the Hayman's nephritis also, for example, the phospholipase A2 receptor where we saw over here their deposition is at the level of the epithelium. So you have characteristically the subepithelial deposits in this particular case. So under the in situ variety we saw and this is basically characterized by the membranous glomerulonephritis, if you will remember, and this is basically characterized by Goodpasture syndrome, along with that the anti-glomerular basement membrane disease, and basically the circulating immune complex disease. The subendothelial deposits are seen in many conditions. We will see later on what are the conditions where we will see the characteristic subendothelial deposits, okay. So this is the two pattern. So as I've already told you, in most of the immune complex mechanism, you will see this characteristic granular pattern. So you can see they are in the form of granules. They are not very linear. Granules means somewhat like this. Linear means completely ribbon-like straight. So the only pattern which is having the linear variety is the anti-glomerular basement membrane disease. Rest all the patterns will contain the granular pattern of deposition. Let us continue the mechanism of glomerular injury. Okay, so we have already read about the different kinds of immune complex mechanisms, that is the in situ immune complex formation. Then we have already read about the anti-glomerular basement membrane disorder. Okay, and we have read about the immune complex disorder as well. Now we are going to understand the mechanism of glomerular injury following immune complex deposition. So we need to understand what is it that happens, okay, once the immune complex gets deposited. So once the immune complex is formed in situ, they are deposited or they are deposited from outside. So whether the immune complex is formed in situ, that is, it is formed at the level of the glomerulus either by the fixed antigens that is already present in the kidney or by any kind of planted antigens. Or if there is any circulating immune complex from outside, if there is any circulating immune complex that is from outside which has actually deposited in the kidney. In either case, whenever any kind of circulating immune complex is depositing, they are going to elicit a local inflammatory reaction that is going to trigger injury. So this antigen antibody complex, once it is formed, they will activate the complement system and they will engage the Fc receptors present on the leukocyte. So they are going to trigger the process of inflammation. So this is going to cause glomerular leukocytic infiltration and proliferation of the mesangial cells as well as the endothelial cells. Okay. So just to sum up, okay, whatever we had read before, under the electron microscopy, if we see the kind of deposits, so mesangial deposition predominantly occurs in IgA nephropathy. Subendothelial deposits classically occurs in lupus nephritis or membranoproliferative glomerular nephritis type 1, also called as MPGN1. Subepithelial deposits is classically seen in acute glomerular nephritis, that is the PSGN. Then the membranous variety of deposit or deposits which are mainly focused on the membrane, that is membranous deposit, is seen in membranous glomerulonephritis, Hayman's nephritis, along with that dense deposit disease, that is also the MPGN type 2. So under the electron microscopy, depending on the location of the deposit, we can have a classification, and there are certain diseases which have a predisposition for the mesangial region, certain disease has predisposition for the subendothelial region, some of them have for subepithelial region, and some have for the membranous area. Okay. Now if you look at the immunofluorescence, I am just summing up whatever I told you. So once there is an immune complex exposure, now remember, whenever the immune complex exposure is very short lived and it is quite limited, in that case, most of the immune complexes, they are cleared by the inflammatory cells. Okay. So if the exposure of the immune complexes is very short lived and limited, then most of them will be cleared by the inflammatory cells, and this is classical of acute glomerulonephritis as seen in post-streptococcal glomerulonephritis. Now if the exposure to the immune complexes for a prolonged period of time, for example as in systemic lupus erythematosus or in case of viral hepatitis, in that case we have a chronic for example, in which conditions you will see such. Okay, so in cases of SLE or viral hepatitis where the immune complexes remain in the circulation for a very long period of time, in that situation you are going to in that situation basically you will see that there is basically deposition over a long period, and it results in chronic membranous glomerulonephritis or membranoproliferative glomerulonephritis. Okay, very important. Now immunofluorescence pattern, as I told you, in just one pattern, that is the anti-glomerular basement membrane disease, leaving this pattern, okay, this is the only pattern which is having a linear pattern of deposition wherein the deposits, they go like this, whereas in rest of the patterns the deposits are in the granular form. So in any of the circulating and in situ immune complex disease, you will see granular type of deposition. Also you have to understand, any antigen which is highly cationic or positive in nature, they will prefer subepithelial deposition. any anion, any ion which is anionic or negatively charged, their deposition will be subendothelial in nature. And neutral antigen, you will see they are those, okay, which are going to deposit in the mesangium, okay. Now looking at the immune complexes, okay, immune complexes which are subendothelial in location, they are usually the result of inflammation, so they are inflammatory in nature, whereas those which are depositing in the subepithelial region, they are usually non-inflammatory in nature. So these are some of the extra points that I have summed up, and I have given you a basic idea wherein what can happen, which deposit can occur where, in which situation, what kind of immunofluorescence patterns you can get, okay, and what type of immune complexes will be inflammatory or non-inflammatory, and they will deposit where, just to get a fair bit of an idea. This is the last image, okay, for this particular injury, that is the immune complex mediated injury. So if you can see the number 1, what kind of deposit they are? Yes, number 1, this deposit is located in the subepithelial region, so they are classically the subepithelial deposits. Okay, number two, they are also, sometimes they say they are in the subepithelial region, but classically they are in between the epithelial cells. So that is why these deposits are also called as membranous in nature. Sometimes membranous and subepithelial deposits are also used interchangeably. The third type of location, now if you see, this is the glomerular basement membrane and this is the endothelium. Now just beneath the endothelium you can see these black deposits. So this is the classical subendothelial deposits. These are the subendothelial deposits. And what are these deposits? Yes, please tell me, what are these deposits? Can anyone tell me what deposits are these which are present? Very good. So these are your mesangial deposits. These are your mesangial deposits. Okay, it's very, very clear. So if in the exam you are asked a visual based question, so you should be able to answer this question very easily. Okay, so now we have completed in details about the antibody mediated antibody mediated reactions. Okay, so what were the pathogenesis where the antibodies were playing a role, that is the humoral immunity was playing a role. Antibody mediated pathology of glomerulopathies were discussed. Now we will discuss what is the role of cell mediated immunity in glomerulonephritis pathology. So although as we can see that most of the antibody mediated mechanisms, they initiate most forms of glomerulonephritis, as we saw before, there is evidence that sensitized T cells, they can also cause glomerular injury and they are involved in progression of some of the glomerulonephritis. So there are lots of experimental studies which can prove. You don't have to remember these points. Just it has been studied that they may have some role. Okay. Now also in many kinds of experimental crescentic glomerulonephritis in which antibodies to the glomerular basement membrane initiate glomerular injury, okay, and these antibodies, they also activate T lymphocytes which propagate the inflammation. So in case of RPGN or rapidly progressive glomerulonephritis, also called as the crescentic variety, it has been seen that though the injury has been started by the antibodies, but the disease process is propagated by the activated lymphocyte. Okay, so very, very important thing is, but though many experimental proofs have been hypothesized, but substantial evidence regarding T cell role is still questionable. Okay, so just remember about the role of T cells in glomerulonephritis. The second is, the third important mechanism of glomerular injury is activation of the alternate pathway. Now alternate pathway, very important. Okay, it is underlying a group of disorders called as C3 glomerulopathy. C3 glomerulopathy. So it is involving a group of disorders called as C3 glomerulopathies. Okay, so remember one thing, that there are certain there are two pathways of the complement activation. Okay, one is the classical pathway, one is the complement pathway, alternate pathway. In the classical pathway, always remember the C1, the early components C1 and C4 are classically involved, whereas in the alternate pathway, if you see, Okay, classically the C3 complements are involved, and therefore one of the hallmarks of the complement alternate pathway of glomerular nephritis involvement leads to decrease in the complement C3 levels. I will discuss about this. Just understand that alternate pathway of complement activation, okay, it is involved in a group of disease that is called as MPGN type 2, or also called as dense deposit disease, and in other types of C3 glomerulopathies. Okay, just remember, we will discuss in details about them when we discuss about MPGN type 2. Okay. So with this we have completed in details about the basic mechanism of glomerular injury, which can either be antibody mediated, wherein we had discussed in detail about the immune complex which was in situ, or it was circulating variety. Okay, and apart from that we had CMI and the role of alternate complement pathway that we have already discussed. So having said all these things, now we will understand what are the mediators of glomerular injury. As we have read about the mediators of inflammation, so there are certain mediators of glomerular injury as well. So what are those mediators? Let us try and understand. So remember, once the immune reactants or the sensitized T cells, means either the antibody mediated or the CMI mediated, okay, once the immune complexes have localized in the glomerulus, okay, so how does the damage will start? So there is a group of cells and group of molecules, okay, that is responsible. So let us see what are the cells which are responsible. So once the complement system is going to activate, they are going to activate the inflammatory system. So just like in any other kind of, inflammatory reaction, over here the neutrophils and the monocytes, they will first come and infiltrate the glomerulus. Okay, largely because of the activation of the complement system. Now you remember from the chapter of acute inflammation that there are many kind of chemotactic agents. There are C3, C5A, C4A. These are all anaphylatoxins. Out of them, C5 is the one which is chemotactic mainly for the neutrophils. Okay. Now not only this, because of the several kinds of immune complexes, they activate the FC receptor of the leukocytes and cause their infiltration into the glomerulus. Now once the neutrophils are going to enter, they will release certain enzymes called as the proteases, which is going to degrade the glomerular basement membrane. Also there will be, whenever there will be inflammation, there will be release of free radicals or ROS that will again cause lipid peroxidation, protein degradation, yes, and DNA damage as well. And there will be formation of arachidonic acid metabolites. Okay, so all of this inflammatory reaction ultimately will result in a reduction in the GFR. Second is the macrophages and the T lymphocytes, which will infiltrate the glomerulus mainly in the antibody and the CMI mediated reactions. Okay, and what is the role of macrophages? They are the major releaser of cytokines. Which cytokines are released by the macrophages? It is the interleukin 1 as well as the TNF that we already remember. Now again, the platelets are also going to aggregate inside the glomerulus in immune mediated injury. They will release several kind of growth factors. Ultimately, what is going to happen? They will cause vascular injury and proliferation of the glomerular cell. Okay, so because platelets are having a role, so antiplatelets have been seen to have beneficial effects, okay, in experimental glomerulonephritis. Now whatever resident glomerular cells are already there, okay, so for example the mesangial cells, the endothelial cells, okay, they will also start to proliferate and they also start to produce all the inflammatory mediators, which is further going to propagate the inflammatory response, causing more amount of leukocytic infiltration. So you have to just write what are the cells involved: the neutrophils, the macrophages and the T lymphocytes, the role of platelets and the resident glomerular cells, especially the mesangial cells. So this were the cells which were involved. What are the soluble mediators which are responsible for the glomerular injury? So as I told you, there will be complement activation. So as a result, in the end, there is a MAC formation, that is the membrane attack complex, which directly will cause the cell lysis. In addition to causing cell lysis, the MAC complex is also stimulating the mesangial cells to start proliferating and to produce other inflammatory mediators as well. Okay, very important. So very, very important. And one thing which is very important is that in some diseases that is called as C3 glomerulopathies, over here there is evidence of complement activation, not because of antibody or immune complex, but because of defective regulation of the complement system. So over here the alternate pathway is classically involved, okay, over here. And remember, mainly the complements are activated by the antibodies, and that is in case of the classical pathway. But there are other pathways also by which the complement can be stimulated, which is not via the antibodies. That is called as the C3 glomerulopathies, wherein the alternate pathway is classically involved. Now the end result is the same for both the alternate and the classical pathway. That is, there will be activation of the inflammatory mediators and release of the inflammatory mediators will be there. Then certain eicosanoids are released. What are eicosanoids? Yes, anything derived from the 20 carbon compound, that is the arachidonic metabolite that we have already read, the prostaglandins, leukotrienes and all the different mediators. I am not going to details. Cytokines, especially interleukin 1 and TNF, which is produced by the infiltrating leukocytes, especially the macrophages. Okay, so they will induce further inflammation, they will cause more release of adhesion molecules, so more infiltration will be there. Chemokines are released like C5A I told you, okay, or MCP1, they are going to attract the different kinds of inflammatory cells. Then certain growth factors like the PDGF, okay, they will cause mesangial cell proliferation, or TGF beta that is released, or fibroblast growth factor GF is released. So they are responsible, all these growth factors will cause proliferation of fibroblast, synthesis of collagen. So ultimately fibrosis or glomerulosclerosis will occur in case of chronic injuries like in chronic long-standing hypertension or diabetes mellitus. Okay. Now the coagulation system is also a mediator of the glomerular damage, especially if you see the fibrin, it is present frequently in the glomerulus and Bowman space in glomerulonephritis. So that is just giving us a clue that fibrin must have a role, and very importantly fibrin is especially present in the RPGN in between the crescent formation that we will see in the glomerulus. The fibrin is classically present over there. Okay, so very important thing is that shows us that the coagulation system is having some role in this glomerular damage. Especially they are thinking that particularly the thrombin may be a stimulus for the formation of the crescent or the RPGN. Now epithelial cell injury. What is going to happen in case of epithelial cell injury? We are talking about both the visceral and the parietal epithelium, but especially of major importance is the visceral epithelium or the podocyte. Now this podocyte injury is common to many forms of both primary and secondary glomerular disease. Okay, and the term podocytopathy has been applied to disease which is causing injury to the podocytes. So podocytes are which type of epithelium? Yes, can you tell me? These are the visceral epithelium. And do you also remember the podocyte, the visceral epithelium? These are the, what are these stuffs? Kya hai ye? The foot process. And in between, what is there? There is a slit diaphragm. If you remember, the nephrin was there, the diamond nephrin was there. Then inside the cytoplasm, there were the different proteins like the actin, CD2 associated protein, and podosin was also there, if you remember. Okay. So podocytopathy is a term which is applied to disease where there is injury to the podocytes. Now this can be induced by either antibodies which are formed against the podocyte antigens, which I have already spoken about, or directly by the toxins or by certain cytokines in certain viral infections like in HIV, okay, or some circulating factors are there which has not been discovered yet, as in case of FSGS. Okay. Now very important, whenever there is an injury to the podocyte, okay, the major thing includes the flattening or effacement of the foot process. This is the major abnormality that is involving the visceral epithelium or the podocyte. Very important term. Okay. Now loss of podocytes, okay, which has a very limited capacity for replication and repair. It may be a feature of multiple injury, especially in case of FSGS, diabetic nephropathy, also in case of MCD, minimal change disease. Now in case of MCD, nephrotic syndrome, usually there is no loss. In fact, there is an effacement of the foot process in case of MCD or membranous glomerulonephritis. In both conditions, you will see effacement of the foot processes. Okay. Now, in most forms of glomerular injury, the loss of normal slit diaphragm is a key event in the development of proteinuria. So we have already read about the slit diaphragm and the structures which are forming the slit diaphragm. Okay. Now sometimes there can be any problem, okay, in the proteins of the slit diaphragm like the nephrin and the podosin. That is going to give rise to hereditary nephritis that we will discuss later. So such mutations, they will give rise to hereditary forms of nephrotic syndrome. So we have already seen this diagram yesterday, if you remember. So this is the classical foot processes. This is the foot process of the visceral epithelial cell. In between, these are the slit diaphragm that we have already seen. Now what happens that sometimes, if you will see, there will be effacement. Means this foot process which is long, this becomes completely flat. Sometimes there might be loss of these foot processes completely. So as a result, they are the point of beginning of the proteinuria, and especially they become important in case of nephrotic syndrome.